Howdy everyone, Matt and Mateo here, coming at you with another orthopedic special test, and this one is for the lumbar spine. It is the repeated lumbar flexion test. Now this test you may or may not have ever heard about, but it's part of the teachings from Mechanical Diagnosis and Therapy, or MDT, or the McKenzie approach, or the McKenzie method, however that you know it as. And Robin talks about this in his first book as a way to help with your classification. So when you're trying to diagnose somebody, trying to determine on what's going on, you can use repeated flexion in your assessment to determine what's going on, which we're going to talk a little bit more right after this demonstration. To perform this test, there are 3 progressions to it. And we're going to start with the lowest one and go up to the highest. You can pick for your patient whatever that you feel is most appropriate, because what we're looking for is any change in symptoms on it. So either positively or negatively. So we may feel a production of someone's symptoms when they do this. Maybe when they stand up, they have a loss of motion in one direction. Maybe things like neural tension returns, muscle strength loss returns, those things. So you're looking for all of those when you do this. Or the person may stand up and go, wow, that feels a lot better. Okay, then we possibly establish a directional preference. So the first one that we want to do is testing it in supine lying, which we're going to demonstrate now. So all you have to do, have the person just lying on their back, laying there, and then all you ask them to do is bring their knees to their chest, give a little extra squeeze. Now they should be trying to curl the lower back when they do that, and they should feel some tension there. And once again, if you start to have any production of their symptoms, or maybe when they stand back up they have any kind of movement loss or any of those other symptoms, it is a positive. The next one is flexion in sitting. So the person is just sitting nice and comfortable on a chair, have their feet out like that, and ask them to reach under them. That's the easiest way, because sometimes if you ask just to bend down, people end up hinging. You want to round the spine and right back up, trying to get to that full end range that they got, and back up. So again, you perform maybe a couple sets, recheck their symptoms. So does it make them better? Does it make them worse? Do you have any kind of mechanical changes? So the last one is repeated flexion in standing. So once again, just like I said, the person is upright, standing tall, you've gotten their baseline symptoms, then all you have them do is bend forward as far as they can go, and right back up, down and right back up. You really want them to round their lower back. You don't want somebody who's just really hinging at the hips. You really want to get a lot of the lumbar spine rounding when they do it. So once again, you're looking for, does this change a symptom? Either makes it better, makes it worse, do we have any mechanical changes? That's what you're looking for. So talking about the research for this test, there is none. It's not a formal test, so there is no research on it. But I wanted to talk about it in terms of the thought process coming in from MDT. Now this test is used very often for a couple things. Like I said, to help confirm your classification, confirm your diagnosis on what's going on. And so why would you want to use repeated flexion? Well, we typically will use this when somebody is kind of confusing. So somebody's coming in, they have like a back pain, maybe there's not really a directional preference. So if you know about directional preference, so if somebody says, easy example, it really hurts when I'm sitting, but if I'm up walking, I feel better. Okay, they possibly have a directional preference into extension. And as we know, that if somebody has a directional preference, their prognosis is better. There is research by Audrey Long that she took participants and they determined a directional preference, and they had the group that did the directional preference, the group that did the opposite of the directional preference, and then a group that just did a control exercise, and the one that went opposite didn't do very well. The control group got better, but the best outcomes when somebody went into their directional preference. So that's what you really want to use this test for, because like I said, person comes in, we have a back pain going on, but we really can't figure out what's going on to determine it. So you may want to use repeated flexion. Now what does that tell us? Well, one, it lets us know if their pain symptoms are mechanical or not. So if somebody starts doing repeated flexion and their pain starts getting worse, okay, they possibly have a directional preference into extension because we made them a little bit worse with flexion. We also want to understand, are their pain symptoms coming from the spine? Because if we start again flexing the spine, should change the symptoms, either make them better or worse. But if it doesn't, what does that mean? Okay, well, it could be coming from the SI joint, it could be coming from the hip, it could be coming from something else that we may need to send off to someone else to understand, because there could be something else going on. So you can utilize it. Now, a key thing with some of those patients is the time and repetition. I've seen people that want to use repeated flexion very, very lightly. They may just take somebody and go, oh, 3 sets of 10, no change in the pain, no directional preference. Keep in mind, sometimes when people are coming in with very chronic pain symptoms, it may not be 30 reps, it may be 50, it may be 90, it may be 150, it may be 150 over 3 days before you actually get a significant change in what's going on. So you really, really need to keep that in mind. Now, you can also use repeated flexion in a couple other cases. So say Mateo has recovered from his very bad back pain, that he couldn't sit or bend or do any of that, and he's feeling much better. We can start using repeated flexion in recovery of function, the repeated flexion test, to see what the integrity of that tissue is. So say he starts flexing a whole lot, we're going to look back at the baseline. So do we start losing motion? So it's more that he flexes forward, he starts losing extension. Maybe it starts to kind of reproduce the symptoms. Maybe it starts to bring on some of the weakness that was going on in the foot. And a key aspect of that, again, is time and repetition, because this, he may be able to do 30 reps in the clinic, he's perfectly fine. But if he did 3 sets of 10 several times a day over 3 days, he may go, yeah, it's kind of bothering my back a little bit. Okay, you're not quite ready to really, really get back in that full end range flexion. We may have to keep kind of going, and you will talk about that with your patient. Additionally, you can use it with somebody who may be a flexion dysfunction, so somebody who just can't really flex. This can come up with cases of somebody has like really bad back and leg pain, and they get very fearful of bending. I've seen those patients, you may have seen those people, they don't want to flex a whole lot, and their spine gets very stiff and they just can't flex. Oh, we can just use repeated flexion just to help loosen up that tissue. So there you go. That's how we use it. Now, let me be a little aware with this, is again, time and repetition. That is a big thing about it. People tend to kind of forget about that thing. When you use this, it may not be just something that you do just a few reps in the clinic. You may need to do it over a few days. And lastly, I will say, don't be afraid to utilize this test and provoke some symptoms. Think about our other special tests that we do. Pain is often a positive. So if you're able to do this, and it may produce a little bit of pain, okay, good. That gives me the confirmation of what's going on. I will say, when you utilize it, educate your patients on it, to not be afraid, to know when to stop, do this, all that. So I just wanted to share that with you. Let me know, do you utilize this in the clinic? What do you think about it? Maybe we need to do some research on it. What do you think, Mateo? Anyway, so let us know down in the comments. I meant to say that. Let us know down in the comments what you think about it. Let's just share. Let's have a discussion on it. So, like Mateo always says, take care of yourself. Take care of your patients. We'll see you next time.